perhaps the biggest controversy right now that we have when we think about using radium-223 is the timing and the patient phenotype, right? So there is one of the biggest concerns right now is, well, I don't want to put you on radium-223 before chemo, because if I go and give you radium-223, the likelihood of you developing myelosuppression, when you receive subsequent chemotherapy is going to be greater. And if you look at the ALSYMPCA data and, in fact, expanded access data, the incidence of grade 3 and 4 neutropenia in the ALSYMPCA was around 1 to 2% for chemo-naive patients. And for those patients who went on to get actually chemotherapy, it was actually around 3 to 4%. And I just remind the group that if you look at the grade 3 and 4 incidence of grade 3 and 4 neutropenia, when we use taxanes, however, TAX-327, SWOG9916, and the early chemotherapy data is between 5 to 7%. So it's not really drastically different in that context. So I think that earlier may actually be probably the right opportunity for this compound rather than using it later. And secondly is when you have pain, how long it takes you to have pain control. Something that actually hasn't been published, and in reality, when I think of who's the patient for, who's a great candidate for radium-223, if you have a lot of pain needs and you need rapid pain control, I personally don't believe radium-223 is the right agent. Correct. You can actually get rapid pain control with systemic chemotherapy within a week of therapy. And if you look actually the median time to pain control on the phase 1-2 data, it's around 3 cycles
3
or
to
so.
4 doses,
so sometimes patients don't have 3 months to wait to have pain control, right? So I think it's an important point that is important to actually re-emphasize to the group, which is, early may be better because you have the time to actually invest on the therapy and not rushing to control pain.
Now with that being said, though, if you had a patient with multiple bony metastases, let's say it's high volume, and you do have one specific spot that clearly is the symptomatic lesion, a lot of people will also start radium as well as give local external beam to that area for pain control. Yep. So a little bit, I'm just going to change the discussion here a little bit. So I think we all agree that it's a huge mistake to wait until these patients become incredibly symptomatic vis-a-vis opioid use to institute this therapy. I think we all agree there are windows, and we need to better define what those windows are. We talked a little bit in the last segment about primary and secondary resistance mechanisms. So I'd be curious to hear the panel's discussion about, given the fact that this is a calcium mimetic agent, that it basically we're not doing anything to the androgen receptor, but it still has a survival benefit. The question in my mind now comes about, and I think we've alluded to this earlier, is, okay, yeah, we routinely will start an androgen axis modulator, whether it's ABI or whether it's ENZA. So the question really is do any of you worry by concomitantly starting a ABI or an ENZA? Could we be forcing a mutation if a patient just has primarily bony disease and causing these cells to develop this secondary resistance mechanisms?
So I think.
Or am I overthinking this?
No. I think that one of the biggest concerns, I think some of us clinically have seen it, and you and I were talking earlier about this, which is, we have these patients who have great responses to oral therapy, and when they progress, boy, you have to be scared of how they progress, because they develop very unusual sites of metastasis. They develop visceral disease, lung disease, and I think that one of the biggest challenges right now, I think, in the castration-resistant setting is how do we develop resistance to these agents, right? And without knowing really how this happens, and Chuck alluded to that earlier, there may be a glucocorticoid receptor mutations and so forth, but without understanding truly how these things happen, it is very hard to understand how people will evolve and progress. But I'll tell you that when you see patients who actually have had great responses to oral therapy and they progress, they actually, to me, they become AR null. They're not driven by AR anymore. And the reality of it is how much of that will be impacted by radionucleotides. I don't think we really understand that, and whether or not the combination will actually really lead to early resistance or not. I'm not sure we know that, and I think it's just mostly of a clinical, type of management rather than, who would ever thought that an alpha emitter would actually lead to survival improvement, right? Yeah. None of us were expecting that for that matter.
And we now can't use your PSA 4-week, 8-week, 12 weeks, because we know that for the most part in the trial, there was not a PSA reduction.
It's a different category of therapy.
Right. So.
Well, there was 16% of patients on Alcimca had a PSA decline greater than 50%. So there is a small percentage of patients who do have PSA declines. But I would argue that when you see a patient and you make that choice of starting RYM223, you have to explain to the patient that PSA cannot be followed in the context of that treatment.
Just to follow from a urology standpoint, I think there are, for those urologists who manage castrate-resistant prostate cancer, I still think there's a lot of confusion about where to sequence radium-223. And just to follow up on the question I asked before, the gentleman who goes on oral therapy, Enza or Abby, suboptimal response, poor response, 12-week, do you ever sequence radium-223 in at that point, or is that too early, or where's the sweet spot?
So we know that in the U.S. that the approval for radium-223 is for those patients who are minimally symptomatic. So Mike and I were talking about this offline, is that as urologists, how many patients do we have that are walking around who are close to super scans, but clearly have 10 to 20 bone mets, who are completely asymptomatic? And they're a walking time bomb as far as I'm concerned.
Or they're stoic individuals.
Yes.
There's a lot of guys
Exactly.
who basically just are tough guys. They don't admit that they have pain, even though if you ask their wife or their daughter, it's usually the daughter who's all over the internet, they'll admit that dad does have pain, but he comes in. I had a physician recently who is still practicing medicine in his early 80s and is trying to manage castrate-resistant prostate cancer so he can maintain his practice. And he needs these products, but he refuses to admit that he has pain.
Again, it's if you ask somebody, do you have pain, that's one approach where you're going to get a yes or no answer, and patients understand the implications of having pain. They're smarter than we are about these types of things, but there are objective ways you can figure this out. Alkaline phosphatase if it's climbing, LDH if it's climbing, albumin if it's dropping. These are all validated markers of disease progression and morbidity. And then the other thing is, and just as a practical point, I always ask people what they do with their day.
Yes,
And
I
how
was just gonna
differently
say that.
is that from 6 months ago.
Describe
And
your day.
You'll be
That's it.
surprised what, and then that's where the daughter chimes in and says, Dad, you're taking 3-hour naps.
And he takes 5 Tylenol or 6 Tylenol a day. And the other thing to remember, and it's the recurrent theme for this entire discussion, is that overall survival in these patients was better with a better ECOG status, a lower alkaline phosphatase. Once again, hitting these patients earlier in their disease state, theoretically. So I think you really have to pull it out.